For most families, pregnancy is a joyful time full of magical anticipation. It can be devastating to learn that something may not be quite right with your baby's development. At Seattle Children's, we're here to take that journey with you.
My fiance and I found out about Kyler having gastroschisis right at 20 weeks, which was his 5-month ultrasound. We had no clue what it was.
So I guess when we first found out was when I was 4 months pregnant with Jesse, and we were on our way to Disneyland. We wanted to find out what he was going to be, or she, so we could buy stuff for him. And we found out that there was, for one, they didn't tell us whether he was a boy or a girl, unfortunately. And they said that there was something there. They saw a mass of some kind.
They told us pretty much that he was getting, his bowels were going to be on the outside of his body when he was born. They didn't know at the time how much was going to be on that side, whether it was a little bit of bowel or moderate amount or a large. So it's pretty much just the thing where you had to wait out the next 4 months and find out.
So we went to Disneyland. We came back and had a series of other appointments and ultrasounds where they explained to us what it was. And at the time, we didn't even know how to pronounce it. We called it that gastro something or another.
With medical advances and current obstetric practice, families usually learn about conditions like gastroschisis during pregnancy. This gives families and medical teams time to work together and prepare.
Well, gastroschisis is a problem where during the development of the abdomen there's a hole that is just to the right of the umbilical cord. And what happens is when the babies are born, you see that there is bowel that should normally be inside that is coming out through this hole.
And basically it's just an opening in the abdominal wall that didn't close, and as a result the intestines are left outside the abdomen. There's actually a time in development where all babies have their intestines outside the abdomen, and then it's supposed to go back in and rotate in a certain way. And in a small percentage of patients, it just doesn't go back in the way it's supposed to. So that's basically what gastroschisis is.
So right now, when looking at the statistics of all babies born, it appears to be about 1 out of every 5,000 births that gastroschisis occurs in.
Is it something that we did? Is it, is it genetic? It's why? Because, it's 1 in, 3 to 5,000. How could you be that one?
Yeah, I mean, we really don't understand why gastroschisis happens. The most important thing that I tell families is that it's nothing that was done wrong. There's no known risk factors. It's just one of those events that happens, and so I think we don't really have a good explanation for it.
So as a parent, when you see your child born with gastroschisis, sometimes it can be quite frightening. You will see the bowels that are normally inside, outside through this hole.
I guess it was shocking to see the intestines on the side like that, when there was as much of them as there was him.
It's very dramatic, and I can remember the first time I saw it as a student. I mean, it's one of the most dramatic birth defects that we see. But in fact, I try to tell families, if you remember nothing else about this problem and what we tell you, it's a problem we can fix. And, losing a baby because of gastroschisis is a very, very uncommon thing. Now, they have issues about their intestines, and we have to help you through all that, but having this be a life-threatening problem is very, very unusual.
Once gastroschisis has been diagnosed, your obstetric team will develop a plan to monitor the pregnancy more closely. You will be introduced to a high-risk obstetrician, also called a perinatologist, to help take care of you and plan for the birth.
With a baby with a gastroschisis that's been identified prenatally, we want to see you more often. Generally, pregnancies are referred to a high-risk OB because there are some complications associated. So let's talk about what they are. Things that we're kind of concerned about that we watch for is that babies with gastroschisis are at risk for not growing as well. so they can be smaller than expected for each point in their gestation, so that we might want to get ultrasounds, let's say every 4 to 5 weeks, just to make sure that the baby is growing spot on, or to get any information that maybe the baby's growth is slowing down. So that's different from a regular pregnancy where you won't necessarily get ultrasounds this often. The other issues with babies with gastroschisis is that we want to watch the bowel that is sort of outside of the abdomen, sort of floating in the amniotic fluid. We don't understand all the mechanisms, but we know that one of the risks is that sometimes the bowel can start dilating, and we want to watch for that. The timing of delivery is ideally a combination of different things. We really would like mom to go into labor on her own. That is the best way to have a successful vaginal delivery, is to not push the issue, and as long as mom is doing okay and baby's doing okay, going into labor spontaneously is always a nice thing to do.
Vaginal delivery is generally preferred unless there are specific maternal or fetal health reasons to do a cesarean. Gastroschisis by itself is not a reason for a cesarean.
At the end of the day, we generally shoot for, if things are going well, we generally like to get to probably 38 weeks, 39 weeks. And then because we want to prepare for the surgical and the special high-risk neonatal needs of the baby, then we do want to bring mom in for an induction so that the team and everybody is ready for the baby when the baby is born. If mom has had a vaginal delivery, she can be discharged really pretty quickly. If she has an uncomplicated vaginal delivery, she can be discharged anywhere from 4 to 6 to 8 hours afterwards.
At the delivery hospital, a team of specialists is ready to care for your baby and to arrange travel by ambulance to Seattle Children's within the first few hours of life. The team is led by neonatologists, pediatricians specialized in caring for high-risk newborns.
The newborn team is usually present in the delivery room when we have a baby going to be born with gastroschisis. After doing a quick newborn assessment of the infant, we then have to stabilize the baby. Because of the exposed bowel, there is a risk for loss of water and heat.
The lower half of the baby's body will usually be placed in a plastic sheet or a bag in order to make sure that the bowels themselves are as moist and warm as possible. During that time, your baby will have a nasogastric tube, so a tube passed from either the nose or the mouth down to the stomach in order to drain gastric juices as well as air. By doing that, we help maintain and limit how distended the intestines can get.
Throughout the newborn stabilization process in the delivery room, we encourage any family member who is present to watch the whole process and be with us and see the baby. After this, we will take the baby to the mother so that she can touch the baby, look at the defect along with the baby, as this may be the only time she gets to see the baby before the baby goes in for surgery. The nurses will then start an IV access and for IV fluid placement, as this baby will not be fed for quite some time.
Transportation is usually organized for your baby to be transferred to Seattle Children's Hospital.
We encourage the family members to either go in the ambulance or follow the ambulance so that they can be with the baby at Children's Hospital. And I always like to reiterate to you all that this defect, as frightening as it looks, the baby is not in any pain due to the intestinal exposure per se, and he is just like any other newborn, shocked to be out in this cold world with a lot of light, and he cries the normal way and looks beautiful, and he's a beautiful baby.
The baby will be admitted to the newborn intensive care unit where the surgeon will evaluate and make a plan for surgery. The baby will remain in the intensive care unit until after surgery, then transfer to a surgical inpatient recovery unit for the remainder of the hospitalization.
When I found out that he obviously was going to need surgery, I think for any parent, for any age kid, it's hard. With him being so little, I was scared.
They were fantastic about explaining everything to us, though, and but it was still a little scary. But fortunately, of anybody to explain to us, it was Dr. Salmon. He's got a very nice voice and just a calming way of speaking to people, and just put us at ease that this man was going to do everything in his power to make sure that Jessie was fine.
They had explained to us that since there was a decent amount out, that there's a couple different ways that they could do the surgery. They explained to us which route they were best going to take. I was scared. It took about 2.5 hours. I think the hardest part was the waiting.
Your baby has a hole in the abdominal wall. At some point, that hole will need to be closed. When that is closed, it depends on how the bowel looks and how quickly the bowel will go back in.
As you can imagine, when your baby's in the womb, the intestines are floating in fluid, they're pretty well protected. Sometimes the fluid, the amniotic fluid, will cause the intestine to be a little bit thicker and maybe shorten a little bit, but generally it's not that harmful to the intestine. But once your baby's born, the intestines have to be inside the abdomen as quickly as possible.
And what we do is, by looking at your baby and looking at how healthy the bowels are, we try to determine what the next step might be. In some babies where there is very little bowel that is out and the bowels otherwise look healthy, sometimes we can place all the bowels back in very quickly after baby is born and close the hole.
Now, sometimes that means going right to the operating room and putting everything back inside and closing up the hole, and we can even make it look like a pretty normal belly button. But sometimes the amount of intestine sticking out is too much and we can't push it all back in at once, so we do it kind of in stages or gradually. And one thing we can do to help that is actually put a little bag. It looks almost like a baggie, a sandwich baggie. It's got a little spring on the bottom. We can put that in place so that the intestine's covered, it's in a sterile environment, it keeps it nice and moist, and we can allow the bowel to just slowly kind of shrink down into the abdomen. Then when we go to the operating room, it's not as difficult to push everything back in the inside. Now there are some babies where so much is out that little baggie that we use isn't enough. We have to take longer. We have to take like 10 days or 2 weeks to push everything back in. So in those situations, sometimes we have to go to the operating room and early in life and sew some plastic material onto the abdominal wall and create a little chimney that we can actually use to enclose the bowel, and then we can push things down a little bit every day and squeeze it down, squeeze it down, squeeze it down until everything's back inside the abdomen.
We can do that because the abdominal cavity can stretch and accommodate the bowels as they're being slowly pushed back in.
One moment at a time, one turn at a time, and it just depended on how much intestines was out, was what Dr. Salmon said.
Then we go back for a second operation to take that plastic material off the abdomen and close it all back up. So usually everything gets closed within the first couple days, but for about 20% of babies, you end up having to have this longer sort of 10-day to 2-week one operation followed by a second operation.
When he came back and I saw that he didn't have, his bowels out in the bag that they had it in, he looked like a normal baby, and I just was like, wow. I couldn't believe it, because the before he went in and the after he came out, totally two different babies. He looked so good.
Intestinal function and feeding are the central aspects of care after surgery. They are also the factors that determine discharge home from the hospital. In fact, criteria for eventual discharge home is that your baby can thrive without IV nutrition.
I often had lots of opportunities because of the wonderful staff and the volunteers at Children's to walk out of the hospital when I needed to. after surgery?
We have several members on our surgical team. Currently, we have 10 attending surgeons. These are senior surgeons who are trained to care for gastroschisis. One of them will be assigned to your baby, and he or she will be making the decisions for your baby while they're here. We also have nurse practitioners. There are 4 of us currently that help answer questions and just support you throughout your hospital stay. We also help you get ready for discharge when that time comes. We have a dietitian always on hand that is very helpful in deciding what we feed your baby, how many calories your baby needs to gain and grow. We also have lactation support for the time if you decide to breastfeed. It's not always an easy time, and our lactation support can help you and your baby during breastfeeding, as well as during the time when your baby's not able to breastfeed, helping you pump and keep your milk supply up. With gastroschisis, one of the main issues we're dealing with is feeding, getting them to gain and grow on oral nutrition.
After we get the abdomen closed, there is actually what may to you seem like a very long, drawn-out period of time. During that first week, there are a lot of things going on. After that, the main issue is on how quickly we can get the intestines to be fed up to full goal feeds. And that period of time can be very frustrating.
When we're starting to feed babies with gastroschisis, we have to start slowly, we have to advance it slowly, because along with being a little bit short, the intestine is a little more sensitive.
And that is because the bowels have been exposed to the amniotic fluid. The bowels may develop a very thick kind of peel that happens on the bowel. All of that contributes to why the bowels may not work as well as they might otherwise do in other babies. So during that period of time, your baby will be getting IV nutrition, and we have specially designed IV nutrition for babies. And by doing that, we can maintain your baby's nutrition until the intestines are able to catch up and until they're able to start taking all the feeds. On average, that may take several weeks to months until your baby is actually able to tolerate all feeds through his or her own intestines.
They may have days where they haven't tolerated the small volume, and we have to start from the beginning, and this can be a very slow and often frustrating problem, and parents can get, it's very easy for parents to get frustrated and have a feeling that, is my baby going to ever get to full feeds? Are we getting anywhere? Are we making steps forward, or are we just standing right where we came? But I want to reassure you, this is just something that every baby goes through.
At some point, when we see that the intestines will start accepting feeds, usually we will start with breast milk that is very gently tolerated by the intestine.
And we know that when they start stooling and having less volumes out of their NG tube, or also known as the nasogastric tube, we look at both of these things to tell us when bowel function has begun. Now, if they start to vomit or show symptoms of irritability or abdominal distension, that they're just not tolerating the feeds, sometimes we have to slow down and go to what was working prior, or even just hold feeds for a period of time.
It's kind of like a dance. As we advance, we see how the intestines do.
If the babies are vomiting a lot and they're not tolerating these small little bolus feeds, sometimes we'll actually drop an NG tube or nasogastric tube. This is a small little feeding tube that goes into the nose, fed down into the stomach, and we can deliver a drip or a continuous infusion, a small amount of breast milk or formula.
So it's either it's going to be a good feed or it's going to be a bad feed. Will there be a spit up? You know, it's all that stuff is what they look at, and it's very important.
The length of stay of 1 to 2 months or longer is one of the most difficult things for families to deal with. It's very hard to be away from their home, their family, the other things going on. They just want to take their baby home.
It's tough going home because we have his crib set up and all that stuff, and you know, you're not pregnant anymore, but you obviously don't have your baby with you at home, so it's a little heartbreaking. The toughest thing for both of us is that even a trip to Walmart, when you see other parents out with their newborns and you want so bad for that to be you. It's just the small stuff that people do on a daily basis that you can't do and you wish you could. You already had to wait 9 months, now you have to wait a couple more.
We encourage you to be at your baby's bedside as much as you can be. Your baby really needs you for bonding. He or she knows your voice, wants your touch, to be held and cuddled. That's such an important thing. We also understand that you have a life outside of here. You have maybe other children, things that need to be done at the house. So we encourage you to have a break, go home, do your things that need to be done.
About 10% of all the babies with gastroschisis will actually have parts of the intestine that are missing, and we call that atresia. And basically it's that the intestine just ends like a dead-end street, and then there'll be parts missing, and then the street starts again. And those babies are particularly complicated. They're the ones that the bowel tends to be much shorter and it seems to take longer for them to start to be fed. So those babies can often be with us for many months. Sometimes we'll feed them to a point where the intestine just gets overstressed, and they'll actually get what's called NEC, short for necrotizing enterocolitis. It's like an infection of the intestine. And in the worst cases, that can progress to actually requiring surgery to remove some of that intestine if it's badly inflamed. Most of the babies, in my experience, who get this neck problem with gastroschisis usually don't need to be operated on. They usually we have to just stop the feedings, let the intestine rest. But sometimes we have to let it rest for a week or two. And so that stalls the progress, and that's what keeps these babies in the hospital sometimes. And the differences between the ones that get out really early and the ones that are here for several months tends to be how short the intestine is. So when that intestine is out in the amniotic fluid, it gets a little thicker and it gets a little contracted, and so the length of the intestine is sometimes affected by that. And that small intestine is the part of your bowel that absorbs the nourishment. So if there's less of it, then there's less ability for your baby to absorb the nutrition. So those babies, when we start feeding them, we have to feed them very slowly, and we can only increase a little bit at a time. So they're the ones that are often here a long time.
Even though this is a difficult time, you have several weeks now to prepare for and consider some things prior to your baby's birth. The things that I think about are finding a pediatrician. This is very important for when your baby leaves the hospital so that the well baby care can be continued. We also like to have a pediatrician chosen for your baby prior to you going home so that we can speak with them and give them an update about your baby prior to them leaving the hospital.
But because of these problems with feeding and the reflux, and how the intestine may not absorb nourishment quite as efficiently, we watch them really carefully to make sure that they are growing and gaining weight. So we'll see your baby back fairly frequently after you leave the hospital. When
we near discharge, there's some important things that need to be learned: how to give your child or your baby medication, how to feed your baby possibly through the nasogastric tube. Those are all things that you're going to need to learn.
At some point, we will feel that your baby is able to maintain all their feeds by their intestine, and that will be the great day that you guys get to go home.
Most often, babies with gastroschisis have a difficult start in the beginning with feeding, gaining, and growing. But after that, they become healthy, beautiful children that can run and play and do all the things that other children do.
The most important thing that I remember feeling, and I still try to do today, that no matter what they were going through or what they're here for, they deserve the opportunity to be treated like a regular child. So even though we had the tubes and the IV pole and everything else, I'd still tote him around the hospital and give him a chance to play and get his feet wet and play in bubbles and get dirty.
Well, I think that it's important to know that the experience has its ups and downs, that there are good days and bad days. And patience. Patience is important.
The most important thing, I'm not gonna lie, it's not easy. It's not an easy journey. It's all you can really give it is time.
I think it's important not to be wedded to a certain result in a certain time frame.
Whether you're in this hospital for 2 days, 2 weeks, 2 months, or 2 years, it doesn't minimize the difficulty of it. I would recommend asking lots of questions.
Once I let go of the notion that I needed Bianna to eat by a certain age, for instance, and let go of the notion that I wanted her off tube feeds by a certain age, everything got a lot easier. So I would say let go of expectations and just go with the flow and enjoy your child.
I know it sounds like such a cliche, but you really don't know what you have in you until something like this comes out and you realize how strong you are. So allow yourself to be that strong. Ask the questions that you need to ask to make sure that you know and understand, and don't stop asking until you do understand, because they will explain it to you.
So I was just fortunate that we are here and pretty much nowhere else, to be honest with you.
If I lived in Vancouver, Washington, I would still drive to Children's Hospital. I wouldn't take my children anyplace else.
I know this is a big bump in the road, and it's a change from what you thought would normally happen, but we plan to really help you get through this time, and your baby should do just fine.
If you are patient and have faith in your physician and your team and the nutritionists who are taking care of you, you will get there and the baby will go home.
At Seattle Children's, we have more experience with babies with gastroschisis than any other hospital in the Pacific Northwest region. We work hard to reduce surprises and anxiety. The staff at Seattle Children's Hospital feels privileged to share this journey with you and your family.